heterogeneous mass with focal necrosis, and this is related to the hemorrhagic characteristics of this kind of tumor. And they can be also associated with calcification within them and with cystic areas. This is not the case, but they said on the literature that have a very similar appearance to another NSGCT tumors. Well, another topic of interest will be the regressed germ cell tumor. That is also called burnout, and it is the regression of a primary testicular tumor despite the widespread advice in metastatic disease. They can be clinically occult, having a normal testis or a small room palpation. So this will be because of a high metabolic rate, and with that compromises the vascular upward to this mass. So, for example, we have on the images on the right, we have contrast enhanced CT of a patient with constitutional symptoms that showed an extensive retroperitoneal adenopathy. This study was followed by an ultrasound that showed a longitudinal, and we have a longitudinal scan showing a partly calcified hypoechoic mass with acoustic shadowing that histopathology confirmed to be a seminoma. So ultrasound is very important in the diagnostic approach to these patients because they will have very characteristic features, and or they can be very small, and they will be detected just by this technique. And they can, on ultrasound, we can see hypo or hyperechoic masses with focal calcifications, as we can see in this example. Okay, so the next topic would be the sex cordstromal tumors that are very rare. They are 3 to 6% of the testicular neoplasms, and they can have single or multiple cell types because of the totipotentiality of the gonadal stroma. So they can have lady, Sertoli, thecal granulosa, or lutein cells, and also fibroblasts in various degrees of differentiation because of the characteristics of the cells. So their prevalence is greater in the pediatric population. The first of them will be the Leydig cell tumor, which is the most common of them. The 1 to 3% of all testicular neoplasms will be a Leydig cell tumor, and they arise from the interstitial cells, and they will have a peak incidence between the 20s and 50 years group. And on the clinical presentation, we'll have a painless testicular enlargement of the Aurora palpable mass. Approximately 30% of these patients will have endocrinopathy, which may manifest as a precocious virilization, impotence, or loss of the libido. So from 10 to 15% of these tumors will be malignant, invading the tunica at the time of the diagnosis. They will be bilateral, so just 3% of the cases. And on the image on the right, we have a sagittal grayscale ultrasound of the right testis of a 16-year-old male that showed a well-defined hypoechoic mass with a mild posterior acoustic shadowing, shown here, and histopathology confirmed to be a Leydig cell tumor. And so the typical characteristic of this tumor by ultrasound will be, just as this example, a small solid mass, homogeneous, hypoechoic with peripheral flow, and they can have also foci or hemorrhage and necrosis up to 20% of the cases, having cystic spaces in the bigger the lesion, the bigger the cystic spaces in these patients. And this is another example of other patient that showed a transverse color Doppler ultrasound of the testis, showing an internal and peripheral vascularity of the tumor, and also being a heterogeneous tumor, predominantly hypoechoic. The next will be the Sertoli cell tumors, and they are less than 1% of all testicular tumors. They will present in all age groups. On the clinical presentation, as the other tumors, we have a painless intratesticular mass. And this tumor is less likely to be hormonally active comparing to the lady cell tumor, although gynecomastia may occur in these patients. So there's three kind of histological types that I listed here, and the ultrasound characteristics of this tumor will be a well-circumscribed tumor, generally unilateral, and it will be rounded or two lobulated. They can have peripheral flow, just as this example, and they can have also hemorrhagic or necrosis within them. And they are also in the type larger calcifying kind of this, and can be bilateral and multifocal tumor, and it also can be completely calcified, but it's very rare. So, for example, this is a longitudinal scan of a multifocal large calcifying cell tumor, the kind of the large cell calcifying, showing calcifications with acoustic shadowing. The next will be lymphoma, and this is 5% of all the testicular tumors. They will be more common in men older than 60 years, where it can account for up to 50% of intratesticular masses. However, testicular involvement is only 1 to 3% of patients with lymphoma. Okay, so they are very malignant, and they're most common bilateral. The most common bilateral testicular tumor is on the clinical presentation. We have a painless intratesticular mass with a diffuse testicular enlargement, fever, weakness, anorexia, or weight loss as constitutional symptoms. By ultrasound, we can have a homogeneous hypoechoic with increased vascularity, not encapsulated but compresses the parenchyma peripherally, and the tunica vaginalis may be intact. Extension to the epididymis and spermatic core will be present up to 50% of the cases. And so we have here two sagittal grayscale ultrasound and power Doppler on the right that shows diffuse homogeneous hypoechoic hypervascular mass of the testicle that histopathology confirmed to be a lymphoma. So finally, but not less important, we're going to talk about the staging of the testicular cancers. The testicular malignancy has one of the most complete throughout staging systems among the genitourinary cancers, because it combines the clinical, radiologic, and serum tumor markers as part of the staging. So the initial staging workup usually involves the CT and MRI of the chest, abdomen, and pelvis, and it will be according to the TNMS system, and the clinical stage will be determined on the basis of the findings, the physical and imaging examination, and obviously the laboratory testing. So the lymphatic spread is very important in these tumors. Most of them will spread first via lymphatics rather than hematogenously, though choriocarcinoma has hematogenous spread. It is a very characteristic feature of this kind of tumor. For starters, we have the T as for primary tumor, and we have this dynamic image showing that the T1 stage is a tumor limited to the testes and epididymis without invasion of the vascular and lymphatic portions. The tumor may invade the tunica albuginea, but not the tunica vaginalis, as we can see it here. And the T2 tumor is limited to the testes and epididymis with a vascular and lymphatic invasion. And so the tumor will stand through the tunica albuginea and also the tunica vaginalis. And so this will be the T2. The T3, we are going to have a tumor embedding into the spermatic cord, as we can see here. And the T4, we have a tumor embedding into the scrotum, and which is considered as a T4. And within the T3 and T4, we can have also vascular and lymphatic involvement of this tumor. So then the next will be the N as for regional lymph nodes. The testicles typically disperses in a predictable way throughout the native lymphatic system. The initial drainage will start through the inguinal ring along the spermatic cord, following the testicular vessels, as I already said at the beginning of the presentation, to the ureteral crossing and dispersing into the retroperitoneum. So there's a very characteristic type of dispersing of these tumors depending of the site of the tumor, right or left. The left tumor of the testicle typically spread first to the left paraortic lymph nodes, just below the renal vein, sorry. And the right spreads first to paracaval and retrocaval lymph nodes. It is common to have a crossover drainage from right-sided tumors to left-sided tumors. However, drainage from the left to right has not been reported to date. The M as for distant metastasis, as we already said, the initial staging will be by CT or MRI, being the CT the first workup. And distant lymph nodes that usually are involved will be in the chest, pelvis, and supraclavicular. And brain imaging may be performed if the patient has symptoms or if the tumor is a choriocarcinoma, which is more likely to metastasize to the brain. The most common sites of solid organ metastatic disease will be the lungs, the liver, and the brain. Tumor markers are used to diagnosis, staging, and prognosis and follow-up of these tumors. They may be higher in specificity, but ultimately diagnosis occurs with orchiectomy and obviously by histopathology. Alpha-fetoprotein is produced by the fetal liver and GI tracts, and so they are normally present in the Jol sac tumors and the mixed germ cell tumors. The human chorionic gonadotropin is usually involved with seminoma and choriocarcinoma, and the lactoid dehydrogenase is not specific, but it correlates with the bulk of the disease, and it used majorly in staging, and it's a marker of tumor burden. And as I said, it can help us to study the growth rate and the cellular proliferation of the tumor. Okay, and so in general, serum tumor markers are used to monitor the patient's treatment response. So they are normally taken before and after orchiectomy, and they are also drawn at regular intervals during treatment and follow up the disease progress. So on the clinical stage 1, we will have a tumor that is limited to the testis, epididymis, spermatic cord, or scrotal skin. And the clinical stage 2, we have 3 divisions, but is primarily limited to the retroperitoneal lymph nodes. And it will have 3 divisions depending on the size of the lymph nodes on their maximal diameter. And the clinical stage 3 will be corresponding to regional lymph nodes and moderately elevated tumor markers or distal nodal or visceral sites of metastasis disease. Okay, so in conclusions, ultrasonography is the primary imaging modality for suspected testicular neoplasms and is able to accurately determine if there is a mass and whether the mass is intra or extratesticular. CT is the primary imaging modality used to screen for metastasis, and in general, serum tumor markers are used to monitor the patient's treatment response and also to detect recurrence of the tumor. Accurately, clinical staging is critical because further treatment depends on the clinical stage of the disease and whether tumor is a seminomatous germ cell tumor or an NSCGT. So we as radiologists play an important role in these patients by identifying tumors at the patient presentation and accurately staging the disease, and of course detecting the recurrence during the imaging surveillance of the tumors. So I don't know if someone has a question, comments.